Muted.
Good morning, and everyone, and thank you for joining our Depression Screening and Treatment in Primary Care webinar. My name is Betsy Boyd Flynn. I'll be the host for today. I see folks are still joining us through the webinar, but I'm going to go ahead and get started so that we can be respectful of everyone's time. First, I want to do a quick sound check. Laura and can you guys hear me okay?
Yes. Yes, we can.
Great. Wonderful. Okay. Before I turn things over to our expert presenters, I want to review a few things about the technology we're using today. Since we have so many of you on the line and everyone is and will remain on listen-only mode throughout the presentation, but we have plenty of time set aside to take your questions at the end. We welcome you to submit them via the question pane on the GoToWebinar control panel. You should see a little question with a plus sign to the left of it that you can click. You can type your questions in, and I'll read your message for any of our presenters to answer. Please also feel free to send me a message via the questions pane if you have technical issues, and I'll do my best to assist you. One question we can answer now: we will send all webinar participants a link to the recording, slides, and additional materials after the webinar. This webinar is available through the Patient-Centered Primary Care Institute, a program managed by the Oregon Healthcare Quality Corporation, or QCOR, in partnership with the Oregon Health Authority and a variety of practitioners and practice transformation and subject matter experts who've worked with practices from all over the state. Together with the experts we partner with, our goal is to get primary care practices connected to a broad array of technical assistance as they work towards the patient-centered primary care home or medical home model of care. We encourage you to visit our website, www.pcpci.org, to access resources, including recordings of previous webinars like this one. You can sign up for our email list on the website, which is how we announce additional web-based and in-person training opportunities, as well as future Institute programs. As I mentioned, the Institute aims to help primary care achieve recognition as a primary care home through Oregon's Patient-Centered Primary Care Home, or PCPCH, program. The model is a set of standards organized under 6 core attributes, which you see here. You can visit the PCPCH program website at primarycarehome.oregon.gov to learn more. The PCPCH program standards are being updated, and practices will attest under the updated model in 2017. For more information on that, visit our website, where you can access a webinar recording from earlier this week that details the changes in the 2017 version of the standards. We'll also be releasing a revised set of online learning modules that incorporate those updates later this year. And now I'd like to introduce our presenters for today. Laura Fisk is a clinical psychologist and wellness center behavioralist at Yamhill Community Care. Dr. Fisk joined Yamhill Community Care in December 2014 and currently runs the Persistent Pain Program and is involved in the development of the Wellness Center. Prior to her full-time role at Yamhill Community Care, Dr. Fisk worked as a behavioral health consultant within 2 small independent primary care clinics. She received her doctorate degree from George Fox University's Graduate Department of Clinical Psychology. In her role, Dr. Fisk enjoys the opportunity to work with individuals and groups by helping members improve their health behaviors and increase their overall quality of life. Jerry Turgeson takes a holistic approach to health, working closely with patients to consider all domains of well-being, physical, emotional, and social. Serving as a psychologist in primary care has allowed Dr. Turgeson to help patients where they feel most comfortable addressing their concerns, and Dr. Turgeson strives to collaborate with all members of the treatment team as they work together to meet the goals of each individual they serve. After earning her psychology degree from George Fox University, Dr. Turgeson completed an internship at Eastern Virginia Medical School and a residency at the Portland VA Medical Center. Dr. Turgeson was born and raised in Yamhill County. Welcome to both of you, and I'll turn things over to you.
Great, thank you. Well, good morning, everyone who's with us. So, take over the control. So Dr. Turgeson and I are hoping to accomplish over this next hour for you is one, to really be able to review depression and then screening, depression screeners that can be used within a primary care setting, and then as well as share practical tools about depression in primary care. And so really focusing on workflows, and then how that can apply for practices both with and without a behavioral health provider. So we like to spend some time on shared decision making. And then lastly, too, we want to expand the information that was presented in part 1 of this webinar series. So Dr. Belinsky and Dr. Hammer, who I hope I'm saying her name right, did the part 1 of the series, and they did an excellent job of overviewing as far as with depression, screeners, as well as treatment, both medication and the non-medication. And so we'll actually, we don't want to be too redundant from their webinar, and so we'll point you guys back to, for those of you who didn't see the first part, to see part 1 to get more of that information. But we'll try to also cover a little bit of overview. So for our new attendees who didn't see part 1, we'll get a little bit of a baseline. So to start, I'd like to talk about depression and the diagnosis of depression. So what we're looking for when we're talking about symptoms of depression is really looking for an individual who's having this abnormally low depressed mood, or even a loss of interest or pleasurable activities. And so when we're looking at a major depressive episode, we're looking for this diagnosis. So an individual experiencing 5 or more of the following symptoms. So again, 1 being the depressed mood, or 1 being a loss of interest or pleasure. And then any of the other symptoms also present. So this could be difficulty sleeping, changes in weight and diet, that just low energy, the fatigue, that worthlessness, and the low self-efficacy, the guilt. And then 2, what can always be a really a telltale sign are thoughts of suicide or death. So this is, again, diagnosis for a major depressive episode. However, depression, there's multiple diagnoses for depression. So depression can look different ways, cannot always be textbook, which sometimes we have to kind of pull symptoms together. So we also know that there's other diagnoses like the pervasive depressive disorder. So this is really a low-grade depression that lasts for 2 years or longer. And then we have depression that shows up in other ways, like in bipolar diagnosis, as well sometimes with substance-induced mood disorder, or due to a medical illness, or when none of the symptoms seem to kind of fit into any of these diagnoses, we have the depressive disorder, NOS. Oh, and then also I want to add in that we also, which we'll talk a little bit about, a screener for postpartum depression, which also is something for us to be screening for and watching in our women who are pregnant. So a little background as far as, or just really understanding of depression, really just understanding as far as the prevalence of it. So we know that between 2009 and 2012, 7.6% of Americans aged 12 and older had depression. And of those statistics, we find that depression is actually more prevalent in females than it is in males. And I'll have to correct this slide here. And it's actually, so individuals 40 to 59 are not the age with the most prevalence of depression, but they are the age with the most recurrent depression. So they're the ones likely to experience depression again after experiencing a major episode. Other research tells us that 2 years ago in 2014, 15.7 million adults aged 18 and older had at least one depressive episode in the past year. And so we find that's 6.7% of all U.S. adults. So for us, working within Yamhill Community Care, so we serve the Medicaid population, we also like to take note that we know that depression is twice as likely in individuals that are at or below the poverty line as opposed to those who are above. So that's something just to also be mindful for depending on your population within the clinic. So this is a chart just to show as far as how that the prevalence is kind of, well, dispersed out. So you can see just the comparison of sex and age group and race. And so we see the actual age group with the highest level of prevalence is that 18 to 25-year-old. And then, of course, you can see how females are almost twice as likely as males to experience depression. So in the prevalence of primary care, so we see that 70 to 80% of antidepressants are prescribed in primary care, and which allows us to also see that prevalence of depression is higher in a primary care setting than in the general population. So as a general population with that 6.7%, we find prevalence in primary care is at 10 to 30%. However, depression is easily missed by many primary care physicians and also the care team. And so part of this is, as was talked about in part one, is that we can conclude that depression looks like a lot of other diagnoses. And so that it's not always easy to tease out what's depression versus some other kind of medical diagnoses or even mental health diagnoses. And so as was talked about in part one, that how like sleep deprivation or a vitamin deficiency or even like anemia can all look like depression. And so sometimes it's easy to skip over depression and to look to treat to other conditions, or when we get busy within that primary care, our office visits, that we don't always ask all the questions, and it can be easy just to miss that. So also give you a little bit more background with depression. So we have severity of depression. We see that depression produces a greater decrease in quality of health compared to other chronic conditions. And so as it was talked about too during part one, that individuals who have depression are at much higher risk of other certain medical conditions, so like diabetes, stroke, heart attack, or heart disease, are at higher risk with depression. And then we also know that it's harder to treat these chronic conditions when an individual is also experiencing depression. And then the kind of effect that it also has is how it's one of the leading causes of disability for ages 15 and over. And it was about a 10-year-ago study where depression was really only second to back and neck pain of having the greatest effect on disability days. So that leads us to cost and understanding the impact of depression. So we see that it costs the United States $13.3 million per year in sick days, and then about $2.2 billion in loss of productivity. So there is a huge cost really with this prevalence of depression. And then in the healthcare system, it's 50% more than other chronic medical conditions. And to make the point again that it's when an individual is experiencing depression, it's much harder for them to be able to manage their chronic diseases. That low motivation, the fatigue, really that lack of self-work makes it so much harder for them to engage in those health behaviors that they know they should in whatever other chronic condition they're dealing with. And then we also know that about 15% of individuals who are diagnosed with major depression eventually die of suicide, and so that's an estimate, and I know those statistics will range. And so with that, we know that up to 75% who commit suicide really saw their primary care provider in the past month. So that really leads us to just understanding kind of this overview of depression, this prevalence, what's happening in the primary care setting, leads us to really the screening for depression and the what, why, when, and how. So I'm going to go over the what and the why, and then I will hand it over to Dr. Turgeson for really the when and the how. So the why, in this year, 2016, the U.S. Preventative Service Task Force updated their recommendations to screen for depression, and so their recommendations highlighted adult population, pregnant women, and postpartum women, and then I believe also too in another report it was adolescents as well. And so, and what they're recommending with the screening is to have the screening itself along with that adequate support systems in place. And so these support systems is the adequate diagnoses, the proper treatment, and then the follow-up as well. And with those really four things put together, it improves clinical outcomes. And what we mean by that is that decrease of depression and really the treatment of it. And so through all of this, we find that it overall decreases our morbidity along with it. And so when implementing a kind of a new screening or really any treatment, we always have to weigh the risk and the benefits. And so what was found when weighing the risk and the benefits between implementing a screening tool is that really the benefits outweigh any of the risks. and the risk or the harm was really small to none. So, in speaking of the benefits, what we know from screening is that, one, it's very quick and objective data when we're using a screening tool. So many times, and we'll talk about the workflow, that an MA can provide the screening tool as they're rooming the patient, and so either the MA or even the provider can quickly score the screening tool when following up with the patient. And then two, it's objective. So this gives us a solid number that we can monitor over time. So we can compare the individual to themselves, so giving the screener during one visit and then again follow up a few months allows for us to see if what we're doing is working. And then two, it also allows us to compare to our population of just providing more data and understanding of the patients that we're serving. So, and also the benefits of screening is that 50% of cases are missed without a formal screening program. So it goes back to when patients are coming in presenting certain symptoms, and so some of them may look like depression, or maybe they didn't even talk about the symptoms that they're experiencing of depression, and it just never gets brought up in the exam room. And so screening can really help recognize some of those either underlying symptoms or what just gets missed when working with a patient. And then to go back to the point a few slides ago, when we're able to control depression, we have so much better control over the chronic illnesses as well. So individuals are more likely to engage in their own healthcare, their own behavior change. They have that energy, that desire, that self-worth to be able to manage their chronic condition. And then again, screening allows us really to assess that if the treatment, the interventions that we're doing is actually working. So I know in part one that they covered quite a bit of the screener, so I'm just going to briefly touch on each of these, but then I'll talk about two of them that I know were not covered during the part one. So the first one for adults, the Patient Health Questionnaire, the PHQ-9. I feel like this is kind of the go-to screener. So it's a great tracking tool in order to recognize symptoms, and then two, to monitor effectiveness of the treatment. And you can use it for patients ages 13 and above. And so I find that the majority of my patients, this is the screener that I would use, and even when I meet them a first time, provide the screener to them just so we're not missing anything and to really get an assessment as far as if they are experiencing depression or not. You know, and even kind of my, I'll see more often if I have an individual coming in and feeling more tired lately and just kind of down, I might go ahead and give her a screener just to see as far as what's going on. Or if my 20-year-old college student comes in and thinks that he's now struggling with ADHD because he's just having trouble concentrating in college, then this would be a perfect screener to want to rule out depression, even with those symptoms. So although you can use the PHQ-9 for adolescents, there is the PHQ-A, which has been adapted to adolescents. And so in this questionnaire is really great. So I think maybe one or two of the questions are worded a little bit more adolescent-friendly, so it talks a little bit about schoolwork or difficulty concentrating on schoolwork. But then what it really does is it hones in on suicide, and so it asks a few extra questions around thoughts of death and suicide. So those questions do not get missed during the screening process. I'm going to skip over the children's screener because I'll talk a little bit more about that in the next slide. But the last one that was talked about during part one was the geriatric depression scale. And so this is a nice 15-item questionnaire that just asks yes or no questions. And so the one thing to note about the geriatric depression scale is that it doesn't ask directly about suicide. And so just to be aware of that. But this one is great. It's almost like a kind of a friendly questionnaire. And so I might use this one with my 78-year-old patient who's recently moved to a different care facility and really isn't playing cards the same way that she used to in her last facility and just isn't quite feeling like it. This would be a nice screener to be able to just see if there's more going on besides just the new adjustment for her. So the two other screeners that were not touched on part one is the Edinburgh Postnatal Depression Scale. So this is our screener that we use for both our pregnant individuals as well as those who are postpartum. And so it's believed to have better validation compared to other depression scales for this population. So it's a 10-item questionnaire. A score of 13 or above indicates major depression. And as you can see, it's a 95% sensitivity and an 84% specificity. And so what we find is that so most mothers, after they deliver, about 50 to 80% of individuals have what we call baby blues. And so usually those resolve within 2 weeks after delivery. But for some women, they do not, and actually turns into more of a depression diagnosis. And that can develop at any time after the first year of delivery. So this is a great screener to be using for your moms that you know that may have had a baby in the last year or so. And then too, we also want to use it for individuals who are pregnant. So what research tells us is that untreated depression during pregnancy can actually increase the risk of preterm delivery as much as if the mom was smoking 10 cigarettes a day during pregnancy. So depression is something that we definitely want to be monitoring in our pregnant population. And then the last scale is our depression scale for children. So this can be used for ages 6 to 17 and with a cutoff score of 15. And it's great for kiddos. And the recommendations don't necessarily require for kids to be screened for depression every time, but it's a good one if you have any kind of suspicion. So if you have a kiddo coming in and having a few more stomach aches than normal and with no real medical cause or reason, or you have another kiddo coming in who's just irritable all the time and just constantly frustrated, now this can be a great scale for them to see if depression might be an underlying cause of some of that. And plus we know that 5% of children and adolescents suffer from depression at any given time, so it's always a good rule out as well. So with the screeners and giving the screeners, it's always important that we're careful that we don't use the results as set in stone. So that although an individual might score 25 on the PHQ-9, and so likely of them experiencing depression is high, it is not diagnostic in itself. And so that's where we want to caution that there should always be follow-up with a screener too, and some sort of diagnostic interview, really just to confirm the symptoms experienced. And so that's so if we just use the screener as a diagnostic tool, that's one side of the pendulum, and we can swing to the other side where we completely rule out depression for any low score, and that's where we also want to caution that. So just because an individual has a very low score on a screener doesn't always necessarily mean that they're not experiencing depression. And so when we see this true in about 1 to 5 cases, and so for those individuals, that's where I might just recommend that to either continue to monitor, or these are individuals that you might want to do a little bit more questioning about, just to make sure as far as their that their symptoms that they're presenting truly don't align with depression, and so just get a little bit more follow-up. And so what we know that all so this quote from this recent research article, that all positive screening results should lead to additional assessment that considers severity of depression and comorbid psychological problems, alternate diagnoses, and medical conditions. And so really what that's saying is that screening is really the start of the full assessment, and so it shouldn't be the assessment. That really it should just lead us down the road to understanding if there really is a diagnosis going on or not. And then lastly, is we want to be able to take in consideration any contextual factors. So if we have someone come in and who recently lost a loved one within weeks or even a month or a few months and is endorsing some of these symptoms, then we want to be careful not to quickly diagnose with depression, but to understand that it could be more situational based as far as why they're experiencing the symptoms that they do, versus an actual underlying depression diagnosis. So with that, I will hand it over to Dr. Turgeson.
Thank you. Good morning, everybody. Now that we have discussed some of the various screeners and the rationale, I'm going to discuss a little bit around potential workflows and integrating evidence-based treatment based on the patient's preferences once a depression diagnosis is identified. So as Laura mentioned, the United States Preventive Services Task Force definitely recommends screening for the general adult population. This is given a B recommendation, which again indicates that there's strong potential benefit and limited risk of harm for our patients that are undergoing screening. And the key is that we really just want to make sure that there is a plan in place to do accurate diagnostics and then have an appropriate treatment and follow-up plan for the patients once depression is diagnosed. Similarly, for our adolescents aged 12 to 18, this is a B recommendation, and really the take-home message is that routine screening is something that we should be engaging in on a regular basis within the primary care setting. I guess it is important to note that currently it's inconclusive for pediatrics, so those younger kiddos under the age of 12, the evidence isn't there to support routine screening. However, the American Academy of Pediatrics does recommend that providers question and ask around symptoms of mood during their routine visits with kiddos. And I find doing routine screens for the pediatric population that I see to be really helpful in gathering quick information and monitoring treatment for those patients that I'm seeing. So this is just a brief confirmation that, again, routine screening is generally recommended by all major organizations, including the American Academy of Physicians and American Academy of Pediatrics. So you can see that the vast majority of national organizations really do recommend that we be engaging in appropriate screening to help assist with intervention and follow-up for these patients. For us here within the Yamhill Community Care CCO, we have the Oregon Health Authority recommendations, which also guide how we implement screening and guide follow-up for our patients. So the Oregon Health Authority has adopted the United States Preventive Services Task Force and recommends that we engage our patients and our care members with routine screening to make sure that we're not missing diagnoses of depression, because as Dr. Fisk mentioned, we do have a rural population, so they're going to be at a higher risk for depression in the context of those psychosocial stressors, as well as higher risk for chronic medical conditions and difficulty managing. So if we can really make sure that we're capturing the salient factors and addressing the factors we can, it's going to help them to be more successful in their healthcare management. When we look at the frequency of screening, currently the evidence is pretty inconclusive on how often individuals should be screened. So again, this is from the United States Preventive Services Task Force, and they identify that an optimal interval is unknown for both adolescents and adults. However, they note for our adolescents that given the difficulty with just generally engaging this population in their healthcare, they tend to only show up to their primary care doctor if they're sick or if they need a waiver to participate in sports, that we should engage in some opportunistic screening and really monitor mood and symptoms of depression whenever we get the opportunity and whenever they're in clinic. For adults, routine screening is recommended, and the United States Preventive Services Task Force really looks at using clinical judgment and consideration of the patient's risk factors. So clinical judgment with when to screen and how to screen can be really powerful, although we do know that there's benefit from having a routine workflow in place. An article from this year, 2016, SPACE really outlined some good recommendations for when to screen and how to screen. So this is a direct quote, although the spacing, bold, and underlining is mine. So the recommendation that came out from JAMA is that those individuals who have a history of depression, it would make sense to screen for the illness at every visit. So these individuals who have a known history or known family history, they're high risk for recurrent symptoms. We're going to encourage routine screening every time they're in the clinic. For those individuals who are at intermediate risk, maybe they have a chronic medical condition like congestive heart failure, diabetes, chronic pain, or a known family history, but they've not previously had a depressive episode, you want to consider screening at least once a year. And then for those individuals who are relatively healthy or not frequent utilizers of their primary care screening, again, the recommendation might be more of some opportunistic screening and screening them at every visit whenever you can capture them in the clinical setting. And then they made the recommendation for this article that if you have the ability to do so, doing some outreach checks to screen could potentially be beneficial for individuals, as they may not be likely to reach out and access healthcare if they're relatively healthy otherwise. For us here within the CCO, the Oregon Health Authority definitely recommends at least annual screening. However, there is the space that additional screening might be important when there's clinical indication. So this is a potential workflow. This is the workflow that we currently use within my clinic. All of our patients are administered a PHQ-2 on an annual basis. This is done on a rolling 12 months, although to be honest, if a patient is coming in and it's been 10 months, we're going to do that screen early while they're there and not risk that they might not be back for an annual screen. So that rolling 12 months is kind of an approximate. The need for a PHQ-2 is identified via a chart scrub that's conducted to our MA prior to the arrival of the patient. So generally 1 to 2 days prior, and the need for a depression screen is considered to be just as important as any other preventative health measure. So the MAs know that does the patient have their PHQ-2 done is just as important as are they in need of a colorectal cancer screen or are they due for a mammogram. So we really put this as being a high priority for our MAs to be checking. When the patient is roomed, they're given a PHQ-2 as part of the rooming process. This may be conjoined with the SBIRT, which is a substance use screener that we do here in Oregon, if there's anyone who's not from Oregon. If the patient screens positive, then the medical assistant gives the patient either the PHQ-9 or the PHQ-A, depending on their age, and that screen is completed prior to the physician entering the room. So the patient is screened and the data is ready to go when the physician walks in the door. They're then able to review and score the screener there with the patient and really engage the patient in a discussion of some of the evidence-based treatment options that they might have available to them. And so within our clinic, we do have a medical home approach to care. So there is a psychologist, myself, on site. But our physicians have a really open discussion with the patients on their values, what's important to them. Do they want to do just a medication approach? Do they want to have follow-up with behavioral health or some combination of the two? I think my providers tend to lean pretty heavily on behavioral health, so there's high encouragement for patients to engage with a behavioral health team. Or for some patients, watchful waiting might be an appropriate intervention. So those are generally the treatment options that are discussed. And then the physician documents the discussion around treatment and treatment preferences, as well as the score into the progress note. The PHQ-9 itself is then handed back to the medical assistant who does the documentation and data entry into our electronic medical record. For us here within the CCO, the PHQ-9 and depression screening is a metric that we monitor very closely. And so on a monthly basis, we then pull that data out of our electronic medical record and provide a reporting to the CCO on how we're engaging our members in depression screening. So this data entry by the MA is a really important component of how we actually track and monitor how effective we're being with depression screening. Based on the discussion around treatment options, we have close follow-up scheduled for the behavioral or for the patient with either the behavioral health provider or the PCP. I guess I should note that our providers definitely are not locked into that annual screen. All of my physicians have a stack of the PHQ-9s that they keep in their exam room, and they provide those screens on an additional basis when they have perceived indication that depression might be impacting the patient's presentation, or for those high-risk patients who are presenting with signs or symptoms, complex chronic medical. Those would be patients that we would be doing more regular screenings on, and my physicians are really quick to screen. So the NCQA has recommendations of 3 follow-up visits within the first 12 weeks prior to the initiation of treatment or diagnosis of depression. And within our clinic, this is done either with a behavioral health provider or with a primary care or some combination of the two. We really kind of triage that out depending on the level of risk that's evidenced by the patient. So for those patients who are more of a moderate risk, we might have a 2-week and a 6-week follow-up appointment and attempt to engage them with behavioral health. Generally, I see patients for an average of 1 to 6 visits. My appointments are 2 to 3 weeks apart, with the exception of those patients who are high risk or very acute, and then I would be seeing them much more frequently. And similarly, the primary care provider would be seeing them frequently for medication management for those high risk. Otherwise, that 2 to 6 week is generally a good medication checkpoint, with myself providing the physician and the medical team updates on how the patient is doing in between. And the last presentation did a really wonderful job of going over cognitive behavior-based interventions for depression treatment. So I won't get into what I do specifically with patients. However, if you guys have questions at the end, I'm happy to answer those. This is a sample workflow that came out from an article in 2004, and I really like this because it provides a nice overview of what this could look like for a clinic that doesn't have a behavioral health provider. So with the workflow that was done in this clinic, rather than doing an anticipatory chart scrub, the provider looked through their schedule on the day of and identified those patients that they wanted to be screened. And then an MA, RN, or in this instance, they had an advanced practice medical student who was in the clinic, provided the two-question PHQ-2. If it was positive, a follow-up screening was done. And then similarly, the provider was provided with that data prior to walking into the room so that they could walk in and counsel patients on treatment options and follow-up plans. If they did a prescription, they did a 2-week follow-up with an RN and then a 4-week follow-up with a physician. For those patients who were interested in behavioral health or some sort of therapy or counseling, they were referred to a case manager who assisted with coordination of care and follow-up. So in this instance, there's not a behavioral health provider who's directly involved, but it's a really nice workflow for how to identify, screen, and then link patients into the community. And I think this point around the provider counseling is a really great opportunity for shared decision-making. So we're going to talk just a little bit around shared decision-making. Shared decision-making is a patient-centered approach to healthcare where we identify the point of concern and really have a values-based discussion with the patient around the pros and cons of different treatment options and really what the patient's preferences are. So it really tries to take out that hierarchical approach to medicine that's historically kind of characterized healthcare and have the patient take a much more active role in engaging with their primary care provider. So it's a very comprehensive dialogue with the patient that takes into consideration the patient and family needs, as well as cues that the care team might see with changes in diagnosis or prognosis or lack of support or any sort of evidence that indicates a shared decision-making discussion is warranted. Shared decision-making for depression is a relatively new area in the literature. However, there's some evidence that supports that might be a really nice point of information or intervention in and of itself, because shared decision-making inherently really seeks to engage the patient and actively or give them an active role in their care and provides a lot of autonomy and empowerment in their own health care, which is inherently helps with overcoming that sense of helplessness and hopelessness that's pretty intrinsic with major depression. This is an article from 2010 that provided a shared decision-making intervention, and they have a nice frame for how they engage patients in discussion around their symptoms, education about depression, and then different treatment options with appropriate follow-up based on the treatment options that the patient selected. This is a really nice frame that could be implemented in any clinic, whether there's a behavioral health provider or not, because it provides just that opening to these are the various types of treatments that are available and what feels most consistent with your needs. Similarly, the Mayo Clinic has a shared decision-making tool around medication management. This is a really great tool that I actually use a lot just for psychoeducation for patients on their medication and common side effects and helping them feel comfortable around why their primary care provider prescribed the medication that they did. So it provides, there's really nice cue cards and information. There's an online version that's coming soon. It's available in English as well as Spanish, some decision aids. My patients love the medication cards. They're bright and colorful and really easy to understand. And the visual components are really nice even for those patients who maybe don't have a high literacy rate. So this is, from a psychoeducation standpoint, something I love and I think a great shared decision-making tool around medication management. Similarly, there's the International Patient AIDS Standards collaboration that has a number of shared decision-making tools that are available for depression. And then I just put up two, but there's also a variety of other organizations that are developing and putting out shared decision-making. So there's the Minnesota Collaborative that I came across last night that has a whole list of shared decision-making tools for a wide variety of presentation. So these are just a few that are out and available, and they can provide a really nice context and frame for providing patients with understanding and education around their diagnosis and treatment options. I'm going to spend the last 5 minutes or so for our time here really looking at suicide in primary care. I feel like we can't do an effective discussion around screening for depression if we don't at least touch on the prevalence and assessment of suicide within the primary care setting. We have new data that came out in April of 2016, and unfortunately it's not good data and shows that the rate and prevalence of suicide actually is continuing to increase. So from 1999 to 2014, which is the most recent data that we have that came out this year, throughout the United States there was an increase in 24% for those individuals who completed suicide. And that pace of increase was dramatically greater after 2006. So not only is it increasing, but from 2006 forward, we've had a rapid increase in the rate at which we're increasing in completed suicides. It's up for both males and females, as well as for all ages, from 10 to 74. And I think this is where a lot of providers and a lot of practices don't think to screen their younger peds patients as well as adolescents. But for this instance, the rate of suicide, the increase was actually greatest for individuals or for females in the 10 to 14 age range. And then the rate of increase was greatest for males in the 45 to 64 age range. So on average, there's a completed suicide every 13 minutes. And for us this year in the Yamhill CCO, it's really relevant to note that rural counties have a higher rate of completed suicide than urban counties do. So if you're living or working in a rural area, this is going to be something that you're definitely going to want to take into consideration. And it's the 10th cause of death for individuals within the United States. What makes this particularly relevant for us here in primary care is that 90% of individuals who die by suicide had contact with their primary care provider in the year prior to their death. 76% had contact with their primary care provider in the month prior, and 20% of individuals who complete suicide actually contacted their primary care doctor within a day of their suicide. And what I think is really remarkable, whether you're in a medical home setting or a traditional setting, is that all of these individuals are twice as likely to have contacted their primary care provider as opposed to their mental health professional in both the year and the month prior to their suicide. So what I really try to encourage to my providers is that they're going to be contacting you even though I may have a relationship with them. So definitely something that we want to be aware of and we want to be screening for. Part of that risk assessment is we're actually screening to rule in the possibility of suicide. It's a relatively low base rate phenomenon. So it's definitely a question that we need to be asking. And I think that having a routine screening program in place can be really helpful for this regular touch-in about the presence of suicide. As the PHQ-9, I don't think it's sufficient to just depend on the screener, but the PHQ-9 has that item 9 that looks specifically at thoughts of death or suicide. And so having that as a base and being able to do some follow-up questions on that is a really nice starting point. Knowing that there's both direct and indirect warning signs, we tend to think about those strong indicators of patients who are actually articulating thoughts of death, communicating that they are maybe stockpiling pills or having intent to harm themselves. But there's additional warning signs that I think are really important for us in primary care that are a bit more indirect in nature. So thinking about increases in anxiety and agitation, purposelessness, hopelessness, a deterioration in health, or high levels of rage or irritability. All of these are going to be additional warning signs that perhaps the patient's mood is deteriorating or suicide is becoming more of a possibility that they might be considering. So in addition to self-reports of depression, all of these additional indirect warning signs might be good signs that a depression screen is warranted and can be a helpful point in gathering some information to effectively address the patient presentation. Don't hesitate to directly ask the questions. I think there's kind of this myth that we think if I ask about suicide, I'm going to make it more likely that the patient will complete suicide. And being able to have a direct and open conversation is really important with patients. So don't hesitate to ask directly, and try not to couch questions such as, "You're not thinking of killing yourself, are you?" Because that's really going to shut down the patient's willingness to have that open dialogue around where they're at. Engaging with community, whether it's for depression or for suicide, is really important. So I always encourage providers to develop a relationship with their community mental health providers. I think there's this sense on the primary care side that you refer patients out and it kind of goes into this black hole of mental health and you're not sure if the patient's engaging or not. So having a direct relationship with your community mental health providers can really help to overcome that, because you have that increase in collaboration because there's a relationship that you're working from. And my standard practice, I tend to keep the vast majority of the patients who are referred to me within the primary care setting. However, that kind of 5 to 10% that I do refer out to specialty care, and I encourage my docs to do the same, is when I refer them to an outpatient specialty mental health provider, I send them with a release of information at the outset. Mental health providers have very different training when it comes to confidentiality and HIPAA. From that working in that medical side, we tend to be much more open as far as discussing patient need, coordinating care, and specialty mental health providers are definitely trained very heavily in keeping all information private and not talking with anyone in the patient's life, including their medical doctor, if they don't have that signed release of information. So I just do that at the outset. I think it's important that we don't leave this all on the shoulders of the primary care provider to follow the relationship development and coordination. So having a designated contact person within the clinic can be great, and someone who can help coordinate the referral. So if you're lucky enough to have a case management, that's fantastic. However, I've seen some clinics who've worked really effectively that have had an MA that's been appointed to develop relationships and help with coordinating referrals and following up with patients about whether they were able to follow through with that outpatient mental health referral. So thinking a little bit creatively, if you don't have a psychologist or a behaviorist or a case manager, that an interested MA can be a great contact point for providers who are trying to contact the clinic, that they can kind of triage and connect with the physician for that doc-to-doc discussion, or they can be a really great resource for helping patients connect in with the community. And then the lifelines are also fantastic. So know your local suicide hotline as well as the National Suicide Prevention Lifeline. Those can be great resources. There's a workflow within one of the clinics that if a patient calls into the clinic and is suicidal and there's not a psychologist or a physician available to do the risk assessment, the workflow is actually to three-way the patient in with the local suicide hotline, and the suicide hotline takes over the risk assessment for the patient that way. So there can be some nice creative ways that you can get those information met. And this is a new resource I'm going to just finish up with because I'm running tight on time. So this is an app that's available on iTunes, Android, as well as Google. So it's Suicide Safe by SAMHSA, and it's a psychoeducational tool for providers and for primary care clinics that talks about identification and risk screening within the primary care setting, using the 5-step evaluation and triage model, which is safety, which is a pretty widely recognized model. So this can be a really great free app that you can download that just gives a lot of information and points to consider for your clinic. So with that, we'd love to take questions for the last 12 minutes around screening, workflows, interventions, anything that might be helpful for you guys.
Hi, this is Betsy. I'll be working with you guys through the discussion portion of the webinar today. So anyone, again, is welcome to submit questions through the question pane on your control panel. You can type in your question and I'll read it out for you for the presenters to answer. And again, just as a reminder, we will be sending all webinar participants a link to the recording, slides, and additional materials after the webinar. So are there any questions out there? I have a few that were submitted earlier several folks asked about specific types of subpopulations, and I know that those may be a little too detailed to go into in much depth, but we had questions about what more to do specifically for adolescent patients, and I'm wondering if either of you could speak a little bit more to that point.
Yeah, I think adolescents are really challenging because like I said, they tend not to be high utilizers of the healthcare system. So we tend to screen whenever they're present and whenever they're available. So whenever they come into the clinic, we provide screening. The PHQ A is a standard part of our adolescent well child check. So that's just something that's done on an annual basis. And then really working to engage with the community and doing community outreach. So something new that we're piloting in our clinic is doing an adolescent well child health fair, and it's fun. We have music and pizza and send outreach letters to the athletic directors at all of the local rural high schools to try to encourage them to get kiddos to come in, whether it's for sports screens or just their routine health checks. And we've been talking about how to reach out and engage with like the local high school health classes to see if we can do some creative ways to engage those students and get them in. Once they're in, once we get them screened, we've had a pretty high success rate with referring them to behavioral health within our clinic. We've been able to identify that as being a good route for adolescents. However, if you don't have a psychologist, I think doing the routine screenings and then developing some really good relationships with pediatric psychologists or mental health providers in your community that you can have that direct referral route to can be a really helpful component.
That's great.
So, community outreach and screening whenever you get the chance.
Yeah, that sounds like that has the potential to be positive in lots of different directions. So we have another question, which is that sometimes providers do not address positive PHQ-9 results after MAs have done these. Do you have any suggestions for improving workflow for providers to address these?
Yeah, I think one of the things that can happen very frequently is that providers feel a little bit overwhelmed, or that maybe they don't have the resources to effectively address a positive screen. And so as much as you can, if you have a behavioral health provider, I do lots of trainings for my providers, so I try to get in on our monthly medical staff meetings and do some sort of training. So whether it's on ACEs and trauma or depression screening, and providing them with direct information on this is how you can address these positive screens. These are effective ways to look at interventions. And so I think equipping them with knowledge and information so that they feel like they have the resources and the tools to directly address can be really helpful. As well as I think one of the things that happens is in a quick, busy day, the medical assistant does the PHQ-9, scores it up, and then is off rooming the next patient, and maybe there's a miss in communication. So making sure that the communication is really tightened up between the rooming staff and the provider, so that when we're moving from room to room and kind of quickly getting patients in and out, that miss in communication as it happens, that the provider is directly aware that there is a positive screen, and knowing the potential resources for follow-up.
Great. That's helpful too. I think I have a question that you may already have spoken to, but I think a little more detail would be helpful. This question came in: how can non-clinical staff support providers working with patients suffering from depression? Do you have tips on how to incorporate, the clinic managers and others in the office to help make sure that this care is given smoothly?
Well, I can start, and I can let Dr. Turgeson follow up. So that's where I think just helping with as far as just that workflow. And so as Dr. Turgeson has mentioned, if you don't have a behavioral health provider present within the clinic, sometimes an MA can be kind of that designated resource to be able to help with the referral process, to help to reach out, even do the follow-up calls for these patients. So many times patients will be given some kind of treatment option, either if it's wait and see, or if it's the starting of an SSRI or some other kind of medication. And sometimes there just needs to be that follow-up phone call maybe a few weeks later, and that can be done with the support staff just to check in to see how the patient is doing. And then again, that they can be the ones that the support staff is really doing the outreach to these other resources, really to help to make sure that there's follow-through and connection, because I really feel that it does take that whole team and doesn't necessarily have to follow fall just on the provider. And I don't know if you have anything else to.
No, absolutely. I think the more that you can engage the whole team, I think it takes the pressure off the provider and really helps with kind of that holistic approach to care. So I would kind of echo everything that Laura said. And then again, education can be really powerful. So educating your, we call them PRs, the people who are answering your phone and your medical assistants, educating them on signs and symptoms to look for. So those direct and indirect warning signs for suicide and risk, those are something that I regularly review and go over with all of our medical assistants and all of the PRRs or the individuals who are answering the phone, because I really feel like they're going to be the front line and the most likely to come into contact, so that they have those ticklers in the back of their mind. And we really talk that it's everybody's responsibility to ask those questions and follow up within the scope of your practice. So if you're the person answering the phone, someone's really agitated, that it's within your scope to say, are you safe? Are you at risk of hurting yourself? And if there's a positive endorsement, then providing that triage to the next level until we can get a licensed provider on the phone to help with a comprehensive risk assessment and triage. So providing education, knowing your resources, being able to engage with the community, and then depending on that support staff to help with some of the follow-up. So I'd agree with Laura that following up with a referral to a community-based mental health provider is pretty overwhelming for a lot of patients and a very difficult thing to do. So if you can have a direct person in mind that I'm going to send you to, I don't know, Dr. Jane across town. She's amazing. I've worked with her on all these patients. I really know her. That extension of rapport can be really helpful. And then having a medical assistant do an outreach a week or two later to say, how are you doing? Are you taking your meds? Were you able to contact Dr. Jane? How are things going? Can be really powerful for patients and helping them feel cared for and really helping the team know of are they following through with the treatment plans or recommendations, or are there barriers that can then be addressed?
Great. That's really helpful too. I think we have time for just one more question. And again, it was back to a specific patient population. I think we had a question about how to connect moms in need with community support. So I think I presume that this is for moms with infants as a subpopulation, folks who might be at risk for postpartum depression. Any tips on that group?
I think the first is going to be doing regular screening for moms. So the American Academy of Pediatrics recommends 2, 4, and 6-month screenings with the Edinburgh postnatal assessment. So making sure we do that routine screening, and then once those moms are identified, identifying what level of care is going to be most helpful for them. So again, knowing your community and community-based support. So we have some local hospital moms groups as well as some community-based mental health organizations that are doing outreach. They go in-home visits for moms. There's a wide variety of both psychosocial and medical-based supports that can help with engaging them in care, both for their health as well as the developmental health of the infant. So having some developmental specialists who can go out to the home and provide parenting and emotional support that way can be really helpful. So knowing what your resources are, really reaching out and engaging. Again, this doesn't have to be the doc that does it, but maybe sending an MA or someone from the staff out to see kind of what sorts of resources are available and how to connect patients in. And then coming up with some set workflows that are most helpful. So we have a really great community organization that we refer to from our medical setting, and we noticed that we were having some difficulty with engaging moms to make it from our clinic to the clinic across town to engage in the mom groups. And so we just did some collaborative problem solving with the organization that we were sending the referral form, but having the organization make a warm call to the patients so that we were sending that information. I was giving a positive endorsement, and then they were receiving a phone call from the receiving organization has really helped to increase that engagement. And then we did, the organization now does a wraparound follow-up call to let us know whether the moms make it. And then if they don't, we have a workflow in place to do some follow-up and outreach. So knowing those high-risk populations and being able to hold them close through some registries and monitoring that way can be really helpful.
Great. It looks like we actually do have time for one more question. Any other questions coming in through the chat window? If not, I'll take one of the others that was submitted earlier. And I think that was, it was, and I believe you did address this too, but any additional information you can share about using non-pharmacological interventions in a primary care setting? I know you were saying that patients often feel more comfortable staying with their primary care provider for some of these kinds of treatments, but do you have more to say about that?
Do I take this one? The evidence and support for non-pharmacological based interventions is really strong. So I think, again, providing training and education to the physicians on from that shared decision-making approach that, yes, medication is an option, but Also, for some patients, watchful waiting might be a really good option, and then having them follow up more regularly with their primary care provider, or having providers feel comfortable to have those discussions around if we don't want to do a medication-based approach and you don't want to see a therapist, how can we help support you? And so behavior activation is going to be really important. So we talk about routine and scheduling, exercise, and really engaging them in values-based actions and behaviors. So if within the course of their depression maybe they're no longer attending a church group or a community-based group, or they're not volunteering like they used to, or they're not cooking dinner, or they've given up their exercise, that kind of taking a couple of minutes to have that conversation with them around how is depression impacting your daily life, and how can we then set some goals, small measurable goals. I always tell patients, don't jump back into your regular schedule full force, but could we set up, maybe you were exercising 30 minutes 6 times a week. Let's start with a goal of 10 minutes 3 times a week, really small, manageable to get you back on track, and then having some follow-up discussions around them. So the non-pharmacological based interventions are really powerful. It's just scaling them in a way that's going to be doable and sustainable to help with that patient self-efficacy. And I have a lot of docs that have really great discussions with patients. If you don't want to go see Dr. Jurgensen, that's totally fine. How are we going to get you on board? And having that 2 or 3 minutes to take those extra discussions to provide that education around the benefits of 30 minutes of moderate cardiovascular exercise 5 times a week and the impact that that can have on depression management.
Thank you for that. That's really great. That's a great answer to help try to activate patients in their own care. Well, that's all the time we have. I want to thank Dr. Fisk and Dr. Jurgensen for your time today and for sharing your wisdom. Again, folks, the recording and slides will be available on the website after the conclusion of this event later today. And this final slide is just a list of some of the previous webinars related to this topic, and a quick plug, please take the post-webinar survey when you see that pop up when you've closed out of the webinar, participants. So again, thanks for attending today, and thanks for your attentiveness and your questions, and have a great day.